labs in which I think Rohit will be talking about. So you've got a wire which can put down, you've got a Fogarty over that, and you can pull out specific clots from the area. You've got Fogarty catheters for grafts. So these are uh, sort of tougher clots to take out. So you've got different catheters, but essentially modifications of the same catheter. What is important now, the principle is that once you are doing the embolectomy, the inflow and the outflow need to be satisfactory. So you have to establish that there is a good inflow, which comes only from experience, and the outflow and the back bleed from the artery, you have to assess that. If you do not get inflow, that means something proximal is still happening. Like Dr. Pai was talking about, there may be a dissection or something, which if you have not done a CT, you wouldn't know. But you need to think about whether you need to go somewhere else proximally for getting a good inflow. Complete the fasciotomy if necessary. Check pulses after closure in the OT. In the OR itself, you would want to check the pulses. And if you've done an embolectomy and you expect the circulation to come back to normal, your pulses should come back. You can wait for some time for spasm, but otherwise it should come back. If it does not come back, something's not right. You can do a completion angio, which even with a C-arm in the OT, you can on table put in a tube, flush in some contrast, and you see what's happening there. And if you need to, you should re-explore that there itself. There's no idea in taking the patient back to the ward and then shifting him back into ours. Let's jump over that slide. Acute in situ thrombosis is something where now you know that your embolectomy may not work. So if you've guessed correctly pre-operatively, then you need to think about in situ thrombosis. So the second thing is, if you've done an embolectomy and your limb is still ischemic, you think that something else is happening, there is chronic disease which is seen on the angio, then you're thinking of acute in situ thrombosis, where we have strategies now with the endovascular stuff that we do. But what I am talking about is restricting myself to open surgery. Rohit will talk about the endovascular stuff. So if I had no endovascular experience or no cath lab available, the next thing that I would do is, if I have not got a good pulse back, I would go back and try to do a bypass or an endarterectomy, take out the chronic clot, treat the chronic lesion, and then get my pulses back. So something like this, you do a bypass in the leg and the upper limb. So that patient who had an embolectomy, we did a bypass from the brachial to the radial artery. So you have anatomical, extra anatomical bypasses where depending on the patient fitness, you decide what you want to do. So hybrid operation theaters are now a boon to the vascular surgeon. All interventions, whether it is open, endovascular, can be done in the same room in sterile environments. Trauma, I will just briefly go over. You can get external trauma like this or internal trauma. And the principles remain life over limb. So that is important to remember. Control bleed with pressure as necessary. Adequately resuscitate the patient. You may need multi-speciality involvement. You may need rigid bony fixation. So you get a patient with a fracture and an arterial injury, you would want rigid bony fixation. Ideally, if you have enough time, if not, you can put a temporary shunt in. You can get secure. So at a point of bleeding, if you have, you need to get secure proximal and distal control.